Hi, I welcome all. I welcome Dr. Suraj and Dr. T. Shah, sir. And first speaker for the session is Dr. Aashiket Sable.
A very good evening to one and all present here. My name is Dr. Ashiket Sable, and I'm going to present a paper on open versus arthroscopic management of scaphoid waist non-unions, a prospective randomized study. I have no conflicts of interest regarding this presentation. So scaphoid non-union is generally defined as a failure of union by 6 to 12 months from injury. As per Mack et al., quote, all displaced ununited scaphoid fractures should be reduced and grafted regardless of symptoms before degenerative changes occur. So we have a lot of traditional treatment options like the open reduction internal fixation with either an iliac crest bone graft or a radial bone graft or a vascularized bone graft. A recently advanced technique is the arthroscopic assisted reduction and internal fixation called the AARIF with either an iliac crest or a radial bone graft. So the purpose of this study was to test the hypothesis that union rates, time to union, and clinical outcomes following arthroscopic bone grafting and percutaneous fixation will demonstrate superiority to open bone grafting and internal fixation in patients with a scaphoid waist non-union. We had a study of 16 patients with a specifically scaphoid waist non-union. It was a randomized study. 9 of our patients were treated with open reduction internal fixation with a headless compression screw with iliac crest bone grafting, and 7 patients were treated with an arthroscopic procedure. The preoperative screening was done by radiographs, CT, and MRI. Follow-ups were done on the basis of clinical examination, radiographs, as well as CT. The inclusion criteria were scaphoid waist non-unions without radiocarpal arthritis, and we excluded smokers, patients less than 18 years of age, and more than 60 years. We used morcellized cancellous bone grafts harvested specifically from the iliac crest in all the 16 patients, and outcome was measured on the basis of pain, strength, range of motion, time to union, and DASH scores. And all 16 of our patients were available for follow-up. So a short description of the technique which we used. This is a scaphoid waist non-union on the CT. Standard wrist arthroscopic procedure was done. The mid-carpal portals were used. The ulnar mid-carpal portal as the viewing portal and the radial mid-carpal portal as the viewing portal. The working portal. This is how we filled the bone void with a cancellous graft from the iliac crest. Once that was done, we did a temporary K-wire fixation to stabilize the fracture under fluoroscopic control, and then we stabilized the fracture using a headless compression screw. We had 15 males and 1 female patient. The average age was around 39 years. Average time from injury to surgery was around 7 months, and average follow-up was around 9 months. Union was obtained in all patients, with 1 patient in the ORIF group showing a delayed union at 4 months. The average time to union in the ORIF group was around 12 months, and that in the arthroscopic group was 10 months. The pain, range of motion, and DASH scores improved in all patients post-operatively as compared to the pre-op scores, with no statistically significant differences in the scores. The patient satisfaction was higher in the arthroscopic group. So to conclude, the scaphoid non-unions can be treated with several different techniques. Advances in wrist arthroscopy, instrumentation, and techniques allows for a minimally invasive way to bone graft and fix these non-unions. So the advantages of our technique was preserving the soft tissue envelope and enhancing the biology, reducing time of union, and it was a cosmetically appealing procedure. The shortcomings were that it had a long learning curve, long-term and multi-center study would be required to establish its reliability. I thank you all for giving me your time. I leave the house open to questions now.
Thanks, Aashiket, for a wonderful presentation. Any questions from the audience?
How did you decide which ones to open and which ones to do arthroscopic?
Sir, it was a randomized study, sir.
Randomized.
Yes, sir. We didn't go for a vascular graft, sir. It was either open, a formal open via the volar approach, or the arthroscopic.
You keep the cast for how many weeks?
6 weeks, sir.
Thank you.
Thank you. Thank you, everybody.
The second speaker is Varun, Dr. Varun.
Good afternoon, everybody. I'm Dr. Varun Manek. I'd like to present our experience and results on 261 Oxford knee replacements that we have done at a mean follow-up of 1 year. Our study period was from Jan 2020 to April 2022. In this time period, we operated about 1,013 knees, out of which 325 patients were offered a partial knee replacement, out of which 250 of them agreed to undergo a partial knee replacement. 11 patients underwent bilateral partial knee replacement. The male to female ratio was 1:1. The range of age was 50 to 84, and the BMI ranged from 21.2 to 41. We calculated the knee society score pre-operatively as well as post-operatively. Our selection criteria was based on where the patients were actually having anteromedial osteoarthritis with intact ACL, which was proved clinically as well as on an X-ray valgus view where the deformity gets corrected. Now, the criteria for anteromedial osteoarthritis is predominantly bone-on-bone contact in the medial joint space. On the lateral X-ray, there is evidence of preservation of the posterior distal femur as well as proximal tibia cartilage and the valgus stress fuse, which ensures that there is a non-contracted MCL. The surgical technique was essentially using the Oxford technique, Oxford basic principles, but not using the Oxford technique. We draped and positioned the patient in a total knee fashion. We did not use a tourniquet. We approached the joint using a minimally invasive subvastus. The primary thing we did was inspected the joint for ACL presence, and we did not do any additional releases unless what was needed for the exposure. The first image shows the picture where we use an extramedullary jig like they use in the Oxford. We fix the jig using a single pin. To avoid stress raises, we do not use extra pins. The other two images shows excursion of the mobile bearing noted in flexion and extension. The literature primarily states that up to 30% of total knee replacement patients are suitable for partial knee replacements. In our study, out of the number that we did, 25.7 patients were operated for a partial knee replacement. The average knee society score pre-operatively was 50, which improved to 87 post-operatively. We faced 3 primary complications where 3 patients got a tibial condyle fracture, the medial tibial condyle fracture. One male patient presented with hemarthrosis at the end of 2 months who was on heavy blood thinners. He was managed conservatively with rest, oral NSAIDs, tranexamic acid, and ice packs. One patient, however, died of myocardial infarctions. In our experience, we did not face any dislocations, no aseptic loosening till the time of follow-up. None progressed to a lateral side wear or a patellofemoral joint wear, and we did not have any primary infections. The advantages of UKR, as stated in the literature, was confirmed by us by confirming that there is good bone stock preservation in need of a future surgery, better functional outcome, and subjectively the patient felt more natural about the patient's knee. In a separate comparative study of our patients with total knee replacement using the forgotten joint score, the patients with partial knee replacement fared better than those operated with a total knee replacement. I'd like to conclude by saying that the Oxford partial knee replacement is promising in anteromedial osteoarthritis with a survival rate of 98% at the end of 2 years, with a patient satisfaction of 91%. However, extra care needs to be taken in female patients who have osteoporotic bones. So what extra thing we did here was we did not use a hammer to fix the tibial plate. We just placed it with hand and used the toffee hammer to just impact it with the cement. After taking this precaution in about 148 patients after that, there has been no incidence of a tibial condyle fracture as yet. There are certain examples of a pre-op and a post-op X-ray without any tibial condyle fractures. Now, this is an example of a tibial condyle fracture at the end of 6 weeks post-operatively. This is an intraoperative image where we fixed it using a proximal tibia plate and at 4 months follow-up. One of the patients who got a tibial condyle fracture at the end of 2 months post-operatively, we converted that patient into a total knee replacement with a long stem. That's it. Thank you.
You keep the tibial plate ready on table?
Yes, sir. Both for all cases, for partial as well as total, in case we have to convert into one. He did not have any history of trauma. So this happens in female patients. This is what we noticed in 3 patients. Whenever, probably because of hammering or the saw, when we take the saw up, it damages the posterior part of the tibial condyle. That is one of the reasons, as it is reported in the literature, even in all the other registries as well. Initially, after this study, in the next 148 patients, we did not do that. So we haven't faced the complication yet. No.
Hello. We welcome the next speaker, Dr. Darshan.
Good evening to everybody. My presentation is a study of clinical and radiological outcome of in situ pinning versus modified Dunn's procedure in patients with slip capital femoral epiphysis. SCFE occurs in 0.3 to 25 out of 100,000 children. It is prevalent in the adolescent age group, with males being more common prone to the disease. It generally requires surgical management to stabilize the epiphysis, achieve early fusion of the proximal femoral physis, avoiding any further displacement or deformity. In situ screw fixation remains the most common treatment for stable SCFE, although recent studies have established an association between the residual deformity of the proximal femur after in situ treatment and the development of femoroacetabular impingement, intra-articular labrum cartilage damage, reduced hip motion, and progression of early onset OA, even when the slip is mild. Advancements in the understanding of the blood supply to the head and in the technique of safe surgical dislocation of the hip and posterior retinaculum containing the nutrient vessels to the femoral head have allowed for development of the modified Dunn's subcapital realignment procedure using the safe surgical dislocation approach. In this study, we compared the results of modified Dunn's procedure versus the percutaneous pinning for the treatment of SCFE in terms of clinical outcomes, which were based on modified Harris hip score and non-arthritis hip score. The radiological correction was assessed by the change in the Southwick angle, and the complications were osteonecrosis of the femoral head, chondrolysis, etc. The objective was to assess the patient-related outcome and the compare and correlation of the radiological outcomes. Our study was a retro-prospective study, which comprised of 40 patients with moderate to severe SCFE. All the patients had stable SCFE, and they were treated surgically, reviewed between the year 2016 to 2019. The Southwick slip angle and loader classification systems were used. Patients were followed up at 6 months and 1 year post-op. Also, post-operative assessments included modified Harris hip score and non-arthritic hip score. As we can see, it is a more male predominant disease, also occurring more on the left side according to our disease. These are some data where we compare our study to the previously done studies. Comparison between the hip range of motions between the two groups. Post 1 year, there was a significantly more range of motion in the modified Dunn's procedure group. Also, the modified Harris hip score and non-arthritic hip score was better in the modified Dunn's procedure group patients. These are two cases, one with 1 year post of modified Dunn's procedure X-ray and in situ pinning X-ray. The mean age group of in situ patients was 12.8 years, whereas the modified Dunn's procedure was around 14 years. And the mean preoperative Southwick angle was 43.85, which improved to 38.7, whereas the mean Southwick angle in modified Dunn's group was 60.7, which significantly improved to 37.7 degrees. The modified Harris hip score and non-arthritic hip score was higher in modified Dunn's procedure compared to in situ pinning groups at 1 year after procedure. There were no interactions between the two groups at the latest clinical outcome. No patients developed complications after in situ group, whereas 2 out of the 20 patients developed osteonecrosis after modified Dunn's procedure. This is one of the patients who developed osteonecrosis. We conclude in our study of management of moderate to severe stable SCFE by using in situ peening and modified Dunn's procedure that modified Dunn's procedure had better clinical and radiological outcomes. Thus, we recommend this procedure as a primary modality in management of such cases. Thank you.
What was the hormonal investigation you had done?
Sorry, sir.
Any hormonal investigations were done?
No, sir.
So slip capital you are supposed to do.
So they were not included in this study.
So normally all these adolescents are obese, overweight.
Yes.
So they have a hypothyroidism or some testosterone.
Yes.
Hypogonadism.
So the basic requirements are required, no? It was not done.
No, it was done, but in our study it was not included, whether it was done or not.
So you all are done.
Yes, yes, of course.
Any discrepancy?
No, those variables, whatever variables we did, chose to put in the study, the hormonal was not included there.
Any question?
AVN was seen in, I think,
2 patients, yes.
When did you see AVN after the procedure? After how many?
One was at 1 year follow-up, and one was at the latest follow-up. That was after 3.5 years.
After 3.5 years,
Yes.
you got AVN.
Yes.
They had chondrolysis also there.
Yes.
What did you do after they got AVN?
After follow-up.
I mean, how did you correlate AVN with the Harris-Hip score? With the AVN, the Harris-Hip score must have gone down.
Yes.
So what did you do after the AVN? Has anything been done after the AVN was seen in these patients?
That,
Okay.
Please accept your this certificate. Thanks. Next speaker, may I invite Dr. Jaideep Dhamele.
Good afternoon, respected chairperson, my dear colleague. My paper is on gradual ulnar lengthening and radial osteotomy in children with multiple exostoses with forearm deformity. Multiple exostoses inhibit the growth of the ulna and leading to acquisition of the varus deformity of the radius in long term. The deformity in forearm present in 39 to 59%. It is a cosmetic problem and functional problem also. Most of the child develop the pain while writing long term. The problem I had just indicated, bowing of the radius, shortening of the ulnar drift of the carpus, dislocation or subluxation of the radial head complex which causing the loss of supination pronation. Natural history, cross-sectional area of the distal ulnar physis is only 1/4 of the distal radius. Distal ulna more commonly involved than radius. More longitudinal growth at distal ulnar physis than the radial physis. Distal ulnar physis contributes more length to upper ulnar length than radius length. That's why they develop the varus deformity. We use the Masada classification. The most common type is type 1, where there is a bowing of the radius, distal end of the ulna osteochondroma. 2A is rare, where both the end of the radius and ulna osteochondroma with radial head dislocation. Type 2B, ulna distal end osteochondroma with radial head dislocation. Type 4, distal end of the radius osteochondroma with shortening of the radius. Our aim to assess the clinical function radiological outcome by ulnar osteotomy, radial osteotomy with mini external fixator. Material and method, this is a retrospective study of the 13 patients, 7 male, 6 female. Most common on left side. So we use the clinical range of movement, flexion, extension arc, supination, pronation arc, functional assessment as by Saturn score, visual analog score for the pain. These are the parameters we record radiology clinically: radial articular angle, carpal slip, ulnar shortening and radial bowing. So we measure all the angles pre-operatively. Indication for surgery is patient is not skeletally mature, ulnar shortening more than 15 mm or exceeding 8%, chronic pain, VAS score more than 7, loss of the function, radial head dislocated with restricted range of movement, worsening of symptom and deformity causing disturbance in day-to-day activity. Operative technique, we first pass the radius nail just like a tens. We pass complete nail. Then we do the where the cora is, we do the osteotomy. Then we pass the ulnar length from proximal to distal. we do the osteotomy, and then we attach our fixator. Either you can use J's fixator, mini external fixator, or whatever new devices come. Then we gradually lengthen proximal block, distal block, some rotation are there. Then we started distraction on day 5. So those, we have in our study 3 patients, we have the radial head dislocated. We connect the ulnar frame with the radial plate. These are the surgical planning now using the 3D model. So plan preoperatively, passes the ulnar wire, proximal block, distal block. We do the percutaneous osteotomy and attach the fixator and gradually lengthen the ulnar to correct the radial ulnar variance and forearm deformity. Post-op protocol, elbow and wrist op movement started on day 1. Distraction 1 mm per wrist started on day 5th. And check radiograph 2 weekly till the desired lengthening achieve, then monthly till consolidation. 1 dose of IV antibiotic, pin track dressing, external fixator with average duration 2.5 will remove and protect an elbow. Result, 13 patients with average follow-up of 48 months. Preoperative average VAS score ranging from 8.2 to 2.3. Pronation, supination improved from 35.6 to 51.3 to 70 and 80.6. Flexion extension has improved respectively 130 to 5 and 130 to 4. Ulnar shortening was improved from 24 mm preoperative to 30 mm postoperative. Radicular articular angle varies from 37.7 preoperative to 26. These are the results. Our results, they are the very first series by Masada. Our study shows the 5 radial head dislocation, average is 8, follow-up is maximum 3.5. Radial head dislocation reduced in all children with excellent result in good. These are the clinical cases, Masada type 2B. You can see we did a radial ulnar osteotomy fixed with the fixator, then gradually lengthen the ulnar. Radial head is already gradually relocated here with full range of movement. Another case, you can see here the radius and bowing ulnar shortening. Here we use only the radius osteotomy because the child is bigger, gradual lengthening of the ulnar. 1 year follow-up, 3 year follow-up. It's gain full range of movement. Advantage, cosmetically superior, minimal invasive, early mobilization, requires shorter surgical time, less expensive. Radial osteotomy, gradual ulnar lengthening, the safe and reliable procedure for treating the multiple exostoses forearm deformity. Thank you. Any question?
Did you do anything for the exostoses also, which you show?
Yes, sir. So if you have seen the first case, so somebody has excised the ulnar exostosis. We excise the ulnar exostosis, but will preserve the physis. The main culprit is ulnar is short, and physis is triangular. Always preserve the growing. We excise because there is supination potential. Some cases we have to release the introstic movement those are present in the arm.
And the radial head sits on its own after you start distraction?
After starting distraction, the main pathology is ulnar is short.
Okay.
It's just like a Montague factor dislocation. If you give the length,
It comes up.
But if there is some fibrous tissue because of neglected.
yeah. So that's
do you excise?
sometime in our series we have one patient we inside the intraosseous movement to release the tethering effect. 5 we have done, all we have closed.
Anything you do to annual ligament?
No, still not. Reported series they have said ki only ulnar lengthening also reduced, but they have said ki 2 procedures they have done the open reduction and annular reduction. Others
I think in children you don't need to do that.
depend upon, sir, because in India patient
6 years.
so many neglected radius and ulnar bone. Depend upon the what grade they are.
Good, good.
Well presented. Thank you, Dr. Dhamele. Next speaker, may I invite Dr. Ashish Kumar Jarika. Dr. Ashish. Next speaker, may I invite Dr. Bharat.
Good evening, everyone. So my topic is pelvic ring injuries, recipe for good outcomes. Background, traumatic pelvic ring injuries has an incidence of 17 to 37 per 1 lakh person per year. Pelvic ring injuries are generally associated with severe other fractures and soft tissue injuries and injuries associated with viscera. It requires the high quality imaging to guide the surgical management and decision making. Functional outcome and quality of life is more important rather than the radiological fixation and early stabilization. Complex anatomy of the pelvis and its bony and ligamentous structures are deep in the surrounding soft tissue, and the proximity of important neural and vascular structures makes the surgery of the pelvis more cumbersome. Main outcome indicators are Majid Functional Score, Orlando Score, and Short Form 12 Health Survey. Aim and objective of the study is to correlate between the radiological and functional outcome in patients with pelvic ring fractures post-operatively. So, study design and methods. Our study was retrospective. We have included 30 patients that are managed conservatively or operatively between the year 2011 to 2020. We have classified them using the TILES classification. And for outcome measures, questionnaire is sent based on the Majid pelvic score, Orlando score, and SF12 survey. And the patients were also invited for the physical examination, radiological follow-up with anterior-posterior inlet-outlet views of the pelvis. Results and discussion. Mean age in our study was 33.3 years. Male to female ratio was 2:1, so 20 male and 10 females. So according to TILES classification, the most number of patients has C1 type of fracture, 10, A3 fracture in 5 patients, B1 in 1, B2 in 4 patients, C2 in 6 patients, and C3 in 4 patients. The average lactate, serum lactate on admission was 2.246 millimole per liter, and 12 patients are hemodynamically stable on arrival. And during admission, HB was more than 10 in 12 patients. Now, requirement of the blood components in patients. 25 patients require PRBC, 8 patients require fresh frozen plasma, 2 patients require cryo precipitate, and 1 require random donor platelets. Now, surgical comparison of the surgical time. So, surgery was finished within 120 minutes in 5 patients. It took up to 180 minutes in 14 patients and more than 180 minutes in 6 patients. Surgery is performed in 1 stage in 7 patients, in 2 stage in 9 patients, 3 stage in 1, and patients who have other associated injuries like urethral injury and perineal injuries and multiple debridement also require. So those are 8 patients. So these are the management and surgery that we did in the patient. External fixator is done in 4 patients. Close reduction internal fixation with iliosacral percutaneous CC screw in 2 patients. Open reduction internal fixation with CC screw in 6 patients. External fixation and iliosacral CC screw in 8 patients. Only iliosacral CC screw in 4 patients. An internal fixator with iliosacral CC screw in 1 patient, and conservative management done in 5 patients. So in our study, chronic pain was registered for 1 patient and sexual dysfunction was registered for 1 patient. Radiological evaluation was performed based on the Mata and Saucedo's method. So this is the case 1. This is pre-op X-ray type B2 fracture, and this is immediate post-op. We done a CC screw and external fixator. This is a 3-month follow-up X-ray showing good union at the fracture site and removal of the external fixator. This is case 2, pre-op X-ray. This is the tile type C1 classification. In this patient, we have done ORIF with Stopaz approach and iliosacral CC screw. And this type C2. We have done iliosacral CC screw on both the side and percutaneous pubic symphysis screws. So to conclude, for recipe for the good outcome, multidisciplinary approach, proper planning and timely management, support from the intensive care and plastic and general surgery, focus on surgical technique with 2 experienced pelviacetabular surgeons, and with dedicated post-operative rehabilitation protocol, we were able to achieve a good to excellent outcome in our patients. Thank you. Any question?
Any question? Okay, Dr. Bharat, please come and accept your certificate.
Yes, any patient has DVT issues? No.
Okay, thank you all the faculty and the convener, and I think we should conclude the session. Thank you. Please all faculty come for the session photograph.
Yes, ready? Look here. Excuse me, sir.